If you've got news, views or events you'd like to share with us and the Chat City team, why not give us an email? chatcity@preston.fm.
And it's lovely now to welcome into the studio this morning, Monday morning, my next guest, and it's Maureen Chadwick. And Maureen is an independent diabetes specialist nurse. Maureen, it's lovely to meet you this morning.
It's nice to meet you as well, Hugh.
A lovely, lovely kind of sunny morning. And I was just saying to Maureen when we were off, didn't have much time to talk, but as I was growing up, my father did have diabetes, and I remember in those days, and we're going back to when I was a child, so you can see looking at me, Maureen, don't judge my age, please.
Just 1 or 2 years ago,
Yeah, that was very kind of you, thank you. Yes, just 1 or 2 years ago. As I was growing up, my dad had diabetes, and in those days, my mother, my sister, we had to learn how to be able to inject him should he need insulin, should he take adverse reaction because he'd not enough sugar in his system. And I can remember in those days, on occasions, actually seeing him when he went into whatever the word would be.
For low blood sugar, it's called hypo or hypoglycemia.
Yeah.
So that's what you would have given him, a special injection for that, to help bring his... to metabolise his body till it produced its own natural sugar.
And I can always, vividly recall those days because I was very young then, and to actually be taught how to give someone an injection as a young boy was quite something.
Yeah.
I mean, I'm sure probably over the years things have developed in many respects. But am I right in thinking that diabetes actually is on the increase rather than the decrease?
It is on the increase, and more so with type 2 diabetes. There's two query 3 classifications of diabetes, but type 1 diabetes is the one that most people know when the pancreas stops producing insulin and you then have to give insulin via an injection, which is what you're talking about. Type 2 diabetes is the diabetes that comes on in later life or the mature onset, and usually, as with all of us, we all have a bit of a middle-age spread, and we all are not as active as we used to do, and because of this the pancreas can't work as well. We will have a lot of you'll hear some people, especially who've got type 2, will have heard of the term insulin resistant, and that is basically part of type 2. The reason why is because the insulin isn't working as effectively.
Right. And would it still be, because again, I was saying there about my own father, and then for many, many years afterwards, I had to go and have regular tests myself to check whether I was diabetic. Yeah. And if I went on medical appointments, the question would always be raised, was the diabetes within the family? Yeah. Why is that?
Because diabetes is connected to other comorbidities or other conditions, such as heart disease, etc. So when you go nowadays, when you were younger, and obviously your father had diabetes, there was research regarding diabetes, but there's been such a huge onset of diabetes in the last 20 years that I've actually been nursing within it, that we can actually screen and pick it up far quicker than what we used to, which then makes you beg the question, is that the reason why there's such a sharp uptake of the diagnosis of type 2 diabetes? Is because we are screening far more earlier. Because the reason why we're screening so much earlier, because if you can keep somebody's control as near normal as possible, then you're going to prevent the complications that come along in later on.
And what are some of the symptoms for diabetes?
It's very difficult because, especially with type 2 diabetes, some people, because as you get older, I know that I've noticed this week, and I've been doing that, but I don't know whether that's because I had a night out with the girls on Friday, but I've been catching myself napping this weekend, and sometimes you can actually feel very tired, very lethargic, perhaps more thirsty than normal, or running to the toilet. Now, I don't want everybody to get really upset and start running to the doctors, because it might not be that. But these are some of the things. So if you start seeing this sort of pattern happen, then it doesn't hurt just to go in and just go and make an appointment with the practice nurse, and all she'll do is she'll just do a simple blood test, and then they'll just check. But now the council have been pushing, the Lancashire County Council have been pushing the 40 to 70-year-old screening, and that is all part of that, to check that for people for early signs of diabetes care. so that we can actually sort it out.
Right. And when you mentioned there are two types, is it type 1 and type 2?
Yeah.
What's the difference?
Type 1 is the fact that your pancreas is no longer producing insulin, and you usually find it in young people, like children usually, and usually anything up to about 30, and some they even say now 40-year-olds. And it's just the fact that the pancreas, for some reason, has just stopped producing the insulin, and then you actually have to give the insulin artificially. So they're the type 1 diabetes. Type 2 is because as you get older and we're getting more sedentary in our lifestyles nowadays. The body is not as working as effectively as what it has done in the past, and that's usually what happens.
So is there anything that you can do to prevent it? I mean, is it a hereditary condition?
It can be hereditary as well. There has been some research showing that there are links to genetic links. I know that within my family, my father's got it, my mother's got it, most of her sisters and brothers have got it, but they've got it very much later on in life. They were in their 60s, 70s before they've actually started with it. But you can stop it, but it's the usual thing which everybody sort of they cringe at. It's the same as everybody else. It's the same as healthy eating and a more active lifestyle, and you can stave it off. There was a research that went round regarding a 600-calorie diet or an 800-calorie diet to prevent it, but that is very difficult. And the one thing that you'd like to get across to people is that, and I tend to do this when I've seen patients on a one-to-one basis, is the fact that I know that it is hard work. It is really difficult because once you've got the diagnosis, it's not going to go away. Even if it goes into remission, it can come back at a later date. So it takes a lot of discipline and a lot of self-motivation. And I know, and I can say this open-heartedly, if I was diagnosed, I would come across the same problems as patients come across, because it is difficult. But the one thing that they should try to remember is that they had a life first, and diabetes is just another bag that they're carrying. So it's about trying to make the diabetes fit in with your life. It's important that you eat 3 meals a day, that you don't go any longer than 4 to 5 hours between each of those meals, that they're balanced, they're healthy balanced, which everybody says, and nobody actually says what that is. But it's just about making sure that you have your 5 a day, at least 5 a day of your fruit and vegetables, that you have carbohydrate on your plate, and that you have your meat as you would do your protein. But you want the bigger part of that plate, you want it full of fruit and vegetables, because that will help take away any excess that needs to take away.
And so diet is
diet
quite
plays
important.
a really important part. Yes, it does take an important part. There's also medications, the diabetes medications that people will be on, and you need to remember to take those as you're actually eating, or what I always tell people to take it when they're eating, because diabetes is a metabolic syndrome. So you're actually, it's about metabolising what's going in through your mouth and out through the body to make sure that you keep that balance. So to actually take diabetes medication when you're actually eating would be the best way, because as the food's being digested, your tablets are being digested, and they're working on what they're supposed to be working.
Right. I do remember, I mean, one of the things my father loved was chocolate.
Yeah, they all do.
and chocolate, apparently, of course, is one of the worst things,
well,
isn't it?
Well, it's not necessarily one of the worst things. It's not something that we actually encourage. There was something which is the same with everybody in healthy eating, that the dark chocolate was being encouraged. But you can get away with having treats. And if any of my diabetes colleagues are out there, they're going to actually put their hands in their head and say, oh God, Maureen, don't say that. But there is a right way to actually have treats, and I'm not going to tell you on air, because it's not good. Leave that up to your health professional to tell you what is the right time to have something if you're going to have something naughty. But there isn't anything that a person who lives with diabetes can't eat. They get ideas in their head, so there's myths going around that I can't have a banana, but why can't you have a banana? If you're going to sit and eat an old banana tree, then yeah, you can't have a banana. But if you're sensible and you have one small banana after a meal, there's no harm in that.
And our regular meals at certain times
is
a good idea.
It is a good idea to make sure that you have regular meals and that you don't miss. Everybody has a problem with having breakfast, but once you start getting into the pattern of having the 3 meals a day, especially breakfast, your actual body actually tells you to have it. You actually start getting the feelings of hungry, because people will say to you, but I'm never hungry when I have to get up and have my breakfast. Once you start having a proper regimented times of meals, you do find that your body actually then tells you when you should be eating.
So, Maureen, when you went into nursing, then did you want to specialise in this area? No, is that right?
No, because most nurses will tell me. I started nursing in 1976, so I'm giving away how old I am too here. But when I started nursing, I can remember nurses. Anybody came in with diabetes used to walk around the bed because it was like, oh my Lord, because it seemed so complicated. But when we sit and older colleagues that I sit with, and I talk about it, we laugh. Because we can remember like the old. I trained when we had the old Nightingale wards, and I can remember lunch times were a nightmare. And I can remember how we used to test the urine and how we used to deal with a hypo, and we were totally dangerous, I can tell you. But it's become a definite sophisticated craft. I started. I was an enrolled nurse, started off, and then converted into a registered nurse in 1991, and then a role came up for a school nurse with responsibility for diabetes children, and I just thought I'll do that because it's a way of learning, and I loved it. I just got into it, and I just totally got the diabetes bug, which sounds absolutely crazy, but you either love diabetes or you don't. But it is so intrinsic into health, and everything that a person with diabetes is told to do regarding eating properly is the same for anybody who hasn't got diabetes. So you're not being told anything different from what you're told as a person. And if you kind of go along to your family doctor or to a clinic, is diabetes something that is quite readily diagnosed these days? Yeah, I mean, it's part of, like I said, it's part of that 40 to 70-year-old screening thing. But if they've got a problem, or they will check for it. It's done per se now. Especially if you've got a concern, they will check for you. And doctors and practice nurses, they are so busy because their clinic times are getting so busy now, and a GP only has an elected 10 minutes in which to see a patient, which is totally. It's silly sometimes because some people really need to sit and talk to you. But the practice nurses do a really good job, and they do keep themselves up to date with what's going on as regarding research, and they have access to the local diabetes nursing team or the diabetologist within the hospital if they need to, because there's more and more inclusion as such. You need to work together because the GP practice really is an extended arm of what goes on in secondary care in the hospitals.
And you mentioned that you worked in school with children who have diabetes. How difficult is it for a child to understand the condition or to actually live with the condition?
Yeah, the same as with yourself, really, with your father. What happened when I did? I mean, I can't. It will probably be the same. The basic will be the same, but a lot of research has gone on now. You actually work with the family. It's a family orientated condition because really, I mean, I had a baby that was like 18 months old, and it can be absolutely. Because you can't explain to an 18-month-old baby why your mum all of a sudden is injecting you with insulin. You can't tell an 18-year-old baby why it's so important and why mum's pulling her hair out because she can't get you to have something to eat. But that would be normal for a child of that age because they can be awkward and they won't eat what you want them to eat, and they do want to eat the wrong things. But you just have to do the best that you can. And as for young people, it's different now because on how each person, you have to take diabetes as an individual because each person reacts to the diagnosis of diabetes in a total different way. Some people pick it up, run with it, and they're fine. Other people, it becomes a really major issue for them. But you do have to take the person on face-to-face and what they do, and you have to make the diabetes fit in with them, not them fit in with you, because that's not fair, because they've got their life and you've got to still make sure that they still have that quality of life.
Right. And when I introduced you, I said you're an independent diabetes specialist nurse now. So I take it that means that you're not within the NHS
No,
anymore.
I left the NHS in October of last year, primarily because I'd worked in an area and found a niche in the market. And with all the changes within the NHS, because I couldn't concentrate on it, I thought the best thing to do was to actually jump in at the deep end, which is exactly what I've done. But my it's about the fact it's the older person who is in a nursing home care home and who's housebound, who can't get into the GP practice for their actual checks. That's who I'm trying to take on board.
Right.
Really.
So it's more. Is it more kind of working? You're able to work one-to-one? Is that the way?
Yeah, it's to do one-to-one, but it's actually to within a GP practice. When you go into a GP or a GP asks you to go to your own appointment, I think a lot of people, because they feel well and there's nothing wrong with them as a person with diabetes, especially type 2 diabetes, they don't do the calling of in because they're doing it just for the sake of it. They're doing it to ensure, because each person with diabetes needs to have an annual review at least once a year. So it's like having a MOT. They're quite fortunate, really, because people who are healthy don't have this. And these are healthy people living with diabetes. And you have an MOT once a year, and it may be that they ask you to come in and have a blood test done every 6 months, or it can be every quarter, and that is just primarily to make sure that your diabetes is controlled properly, that the medication that you're on is working effectively. That's all it's for. But you are invited into the GP practice. Now, sometimes because of the workloads that the GP practice and practice nurses have, and this isn't a criticism in any way whatsoever, because I've worked within practice and I do understand totally, it sometimes can be a bit difficult to actually get out there to a nursing home, care home, or into a person's own home to do that diabetes check. And my idea is that I'll go and do it for you.
Right.
Basically, that's what it's for. Yeah.
Okay, well, Maureen, and also, if people want to find out more, the contact details now where they can find out more about you and about your independent specialism.
I'm actually I'm under the name of Diabetes Complete Care UK. If you want to contact me via the radio station, that's fine. That's okay. And then I can leave details for you to contact me if that's what you want to do.
Whichever, but it's Diabetes
Complete Care UK.
Diabetes. And anybody, as you said earlier, you wouldn't want to panic anyone when we talk about symptoms, because often with many illnesses, symptoms can be quite similar.
Oh, yeah, they can be. It's like when you get a cold or flu, and people, especially with young children, they'll lose weight really quickly, and if they're drinking a lot and going to the toilet a lot. But you've got to be realistic. If you are drinking a lot, you are going to go to the toilet a lot. If it's winter time and you've got the central heating on, you're hot, so you're going to. There's lots of bugs going around, so you're going to get colds, flu, etc. So you're going to drink more and go to the toilet more. So I haven't said all the symptoms to frighten people. If you want to look up more information, you can go onto a website that's called Diabetes UK, which is the largest diabetes charity in Great Britain, and they'll help you. They'll help you to work out what actually is going on. But the best person, if you are concerned, is your GP. Yeah. Right. Well, on that note, can I thank you very much for coming on to Chat City this morning? It's been lovely to meet you. Thank you very much. Thank you. Thank you.
Thanks for listening to our podcasts. But don't forget, Chat City is live weekdays from 10 till noon on 103.2 Preston FM.